Obesity is a growing global driver of cancer mortality, but its burden does not fall evenly between the sexes. Women are experiencing disproportionately higher rates of obesity-related cancer deaths, a troubling and often overlooked disparity in public health. While obesity increases cancer risk in both men and women, the underlying biological, hormonal, and social mechanisms make women particularly vulnerable. This gender-specific risk is not only significant in magnitude, but also underrecognized in cancer prevention efforts, leading to missed opportunities for early intervention and tailored care. One major reason women face a greater burden of obesity-related cancer mortality is the strong link between body fat and hormone-sensitive cancers. After menopause, a woman's ovaries cease to produce estrogen, and fat tissue becomes the primary source of this hormone. In women with obesity, increased adipose tissue leads to chronically elevated estrogen levels, which significantly raise the risk of developing estrogen-responsive cancers such as breast, endometrial, and ovarian cancer. These cancers are not only more common in women with obesity, but also more likely to be aggressive, recur after treatment, or be detected at later stages, especially in populations without regular screening access. Endometrial cancer, in particular, has emerged as one of the fastest-rising cancers among women and is strongly tied to excess body weight. Women with obesity are estimated to have a 2 to 4 times higher risk of endometrial cancer compared to those with normal weight, and for women with severe obesity, the risk can be more than six-fold. This cancer often presents with subtle or dismissible symptoms, and delayed detection can lead to worse outcomes. Postmenopausal women, especially those with other obesity-related conditions like type 2 diabetes or hypertension, may also experience diagnostic delays due to overlapping symptoms or lower clinical suspicion of cancer. Breast cancer remains the most common cancer in women worldwide, and obesity significantly affects both risk and survival. Obesity is particularly dangerous for postmenopausal breast cancer, where the hormonal milieu driven by fat tissue promotes tumor growth. Moreover, obese women are more likely to be diagnosed with larger tumors and more advanced disease. Imaging techniques like mammography can be less sensitive in women with higher body fat, further contributing to late detection. After diagnosis, women with obesity are also less likely to receive appropriate chemotherapy doses due to concerns about toxicity and are more likely to experience complications from surgery or radiation therapy. Beyond biology, social and healthcare system factors contribute to these disparities. Weight stigma and gender bias in medical settings often discourage women from seeking care or from receiving unbiased attention when they do. Women with obesity may delay cancer screenings due to shame, fear of judgment, or previous negative healthcare experiences. Even when care is accessed, subtle provider biases may result in underassessment of symptoms or the assumption that weight is the root of all health problems, leading to misdiagnosis or incomplete evaluations. Compounding this, women in lower socioeconomic groups, who face higher rates of obesity due to systemic inequalities in access to healthy food, safe spaces for exercise, and quality healthcare, are at especially high risk. These women often have fewer resources for preventive care, limited cancer awareness, and more difficulty navigating the healthcare system. In many regions, cultural norms around female body size, aging, and health can also interfere with timely recognition of obesity as a medical issue or cancer as a pressing threat. Obesity can also affect how women respond to cancer treatment. Fat tissue alters drug metabolism and can blunt the effectiveness of chemotherapy and immunotherapy. Obese women are more likely to experience treatment delays or interruptions due to complications like poor wound healing, increased infection risk, and pre-existing conditions such as diabetes or cardiovascular disease. These comorbidities, which are themselves more prevalent in women with obesity, significantly worsen cancer survival rates. Despite these well-documented risks, public health messaging about obesity and cancer remains largely gender-neutral or even male-focused when discussing metabolic diseases. Many campaigns fail to highlight how profoundly obesity increases women's risk of some of the most deadly and common cancers. Likewise, obesity prevention programs often target younger audiences or focus on aesthetic outcomes rather than survival and health. This leaves many women unaware of the life-threatening implications of excess weight, especially in middle age and beyond. Addressing this disparity requires a gender-informed approach to both obesity and cancer prevention. Education campaigns must explicitly link obesity with female cancers, not only to raise awareness but to normalize proactive engagement with health services. Screening programs must be strengthened and adapted for high-risk women with obesity, especially for cancers that currently lack effective early detection methods, like endometrial and ovarian cancer. Healthcare providers must receive training to recognize and mitigate bias in clinical care, ensuring that women with obesity are evaluated thoroughly and treated equitably. Research funding should prioritize studies that examine the intersection of gender, obesity, and cancer outcomes, particularly in underrepresented groups. Lifestyle interventions must be tailored to older and high-risk women, with sensitivity to cultural and psychological barriers that prevent engagement. Most importantly, the medical community and public health systems must stop treating obesity in women as a cosmetic issue or a moral failing, and instead recognize it as a biological force accelerating cancer mortality at alarming rates. The rise in obesity-related cancer deaths among women is not inevitable, it is preventable. But only if we recognize the gender dimensions of risk and take action now to close this deadly gap.